malacia, neurological complications, hemodynamic instability, low cardiac output syndrome, low urine output that requires dialysis, and open sternum in a patient. Now, the fast tracking and early extubation, the advantages of fast tracking and early extubation in patients are there will be fewer ventilator associated complications like accidental extubation, laryngotracheal trauma, mucus plugging of endotracheal tube, pulmonary crisis from endotracheal suctioning, barotrauma from positive pressure ventilation, ventilator associated pulmonary infections, and atelectasis. There is a reduced requirement for sedatives and analgesics, greater hemodynamic stability in patient, more rapid patient mobilization is possible with early extubation and fast tracking. So earlier ICU discharge and decreased length of stay of patient. The benefits of early extubation are known as it is, but the benefits are evident in patients with single ventricle physiology after superior cavopulmonary anastomosis like Glenn and total cavopulmonary anastomosis like Fontan. Mean pulmonary artery pressures are decreased immediately post-extubation with a resultant increase in cardiac output and cardiac index. There's an improvement in mean arterial pressure immediately after extubation in patients with both stable as well as unstable conditions after the total cavopulmonary connection procedure. This is just a diagram that shows a picture of a bidirectional cavopulmonary shunt, that is a Glenn, and the complete cavopulmonary shunt, that is a Fontan. The Glenn and the Fontan surgery goal is a successful and optimal functioning of the circuits. Good pulmonary blood flow will ensure good systemic blood flow and systemic oxygen delivery. Good pulmonary blood flow depends on there is a systemic venous pressure minus the pulmonary venous pressure. So for a good passive forward blood flow, we require an adequate preload. There should be a low resistance, that is low resistance unobstructed pulmonary circulation. Thus, optimal forward pulmonary blood flow in this Fontan and Glenn is directly proportional to the low thoracic pressures. Principles of ventilation in Glenn surgery. Goal is to increase the pulmonary blood flow and systemic oxygen delivery. Any increase in SVC pressures, pulmonary artery pressures, airway resistance, it will adversely impact pulmonary blood flow, cardiac output, causing systemic desaturation in the patient. So, for adequate ventilation of these patients, adequate ventilation in these patients is achieved by negative pressure ventilation, reducing the PEEP, and spontaneous respiration in these patients as early as possible, and sitting position. Principles and nursing sitting up these patients, avoiding needless sedation, and we have to accept modest hypercarbia around 45 because that will cause cerebral vasodilatation and it will reduce the SVC pressures. And try to extubate these patients as early as possible. Usually accepted saturation is around 85 in these patients. Principle of ventilation in Fontan surgery are also more or like same. Goal is to increase the pulmonary blood flow for improved systemic oxygen delivery. This is achieved by negative pressure ventilation, reducing PEEP in these patients, and trying to achieve spontaneous respiration as early as possible, avoiding needless sedation, early extubation, and acceptable saturation in these patients is 100%. In a recent large analysis of patients who are undergoing extracardiac total cavopulmonary connection, early extubation was associated with reduction in total ventilation time, fluid administration on the first post-op day, significant decrease in the hospital length of stay, and there was no increase in reintubation rates, that is extubation within 48 to 96 hours, or morbidity or mortality. The general benefits of early extubation are the hemodynamic parameters like common atrial, mean pulmonary artery, and mean blood pressures were found to be more favorable in the first 12 post-op hours, as was the duration of inotropic support. And other parameters like base excess, fluid balance were favorably associated with early extubation. Decreased length of chest tube days similarly showed an association with early extubation in separate institutional studies. No increase in reintubation rates or morbidity or mortality have been detected with early extubation. There is a definite reduction in sedation required for endotracheal tube tolerance. There is decrease in risk and exposure to airway trauma, ventilator-related infections, suction-related adverse events in ICU if we extubate these patients early. The use of ventilator and related personal requirement and psychological relief to the families who are supporting these pediatric patients. And it has been seen that chronic exposure to sedation in the neonates leads to long-term morbidity such as neurodevelopment morbidity in both experimental as well as clinical settings. So translational benefits of early extubation demand a protocol that goes beyond extubation and continues throughout from hospital admission until the hospital discharge. That is why early extubation should be implemented in ERAS protocols in order to maximize benefits in terms of hospital length of stay and cost. This is a table which shows a compilation of results from various studies on fast tracking after repair of congenital heart disease. These all studies have like in all these studies, they have tried to go for early extubation or immediate extubation in these patients. And all of these studies have concluded that most children, including neonates, can undergo complex heart surgery, who undergo complex congenital heart surgeries. They can be safely extubated, like early extubation can be safely done in them without and this will add to the benefit of decreasing the hospital or ICU length of stay, early mobilization and hospital stay in these patients. This is a study by Tirota et al., where they have the 3-year experience with immediate extubation in pediatric cardiac patients after congenital cardiac surgery. In this study, they concluded that immediate and early extubation was significantly associated with various factors like patient age, size, duration of the CPB, use of certain anesthetic drugs, and amount of blood loss and blood replacement. And immediate extubation can be successfully accomplished in majority of pediatric patients who are undergoing congenital heart disease surgery, including in a minority of infants. This is a review article. This is a review article by Rajneesh Kumar Garg et al. In this study, they concluded that it was a review article basically, and they found that most of the children, including neonates who are undergoing congenital complex heart surgeries, they can be safely extubated in the OR based on the assessment of intraoperative course of these patients. This is a study by Varghese et al., where they're sharing their 5-year experience. This is a retrospective study of 5-year experience with immediate extubation after arterial switch operations for transposition of great arteries, TGA. And in this study, they concluded that in their cohort of infants post-repair for TGA, 56% of these patients were extubated immediately in the OR. Greater CPB time, greater cross-clamp times, and temperature less than 30.4 degrees centigrade were associated with lesser likelihood of immediate extubation. However, immediate extubation was associated with a shorter ICU length of stay. So each age group and surgical group will have different expected rates of success with early extubation. Potential risk factors for extubation failure being chromosomal disorders like trisomy 21, neonates and younger infants, airway anomalies, patients with longer CPB times, low volume surgical centers, and lack of dedicated cardiac ICU. Now, this is a study from the same JCVA. Was study by Vivian G. Nasser and James A. Denardo, where they have discussed about the cons of extubation in the operating room after pediatric cardiac surgery. In adults, extubation time is considered as a quality benchmark in cardiac surgery that as defined by the Society of Thoracic Surgeons. So establishing such benchmarks for pediatric patients who are undergoing corrective cardiac surgical procedures is more complicated. Given the heterogeneous nature of population regarding age, procedure complexity can be from the simple ASD to biventricular repair and coexisting risk factors such as genetic syndromes. So it is also necessary to recognize the rate of failed extubation and the clinical impact of reintubation, because reintubation as it is a risky procedure with life-threatening consequences like profound hypoxemia. It can cause cardiovascular instability, arrest, and moreover, it will lead to another course of mechanical ventilation with its risks and exposures like ventilator-associated infections, airway trauma, need of sedative infusions. So it is better to prevent reintubation as far as possible. In patients younger than 1 year of age, the rate of reintubation is 10.7%, and this has been attributed to agitation that necessitated an escalation in sedation, leading to respiratory depression and reintubation. Other causes for reintubation included bleeding, arrhythmias, bleeding in 18% patients, arrhythmias in 14% patients, stridor, increased work of breathing in 5% patients, respiratory failure in the OR in 5% patients, and cardiogenic shock in 5% patients. And extubation failure has been determined to be an independent risk factor for worse clinical outcomes, as I've already told. And failed extubation prolongs length of stay in ICU and hospital stay, as well as mortality in patients with failed into this extubation is higher. In a series of 416 neonates among 234, that is 56%, who underwent immediate extubation, 10.7% required re-intubation, either immediately or within 24 hours after admission to the ICU. So the authors concluded that opioid-related respiratory depression was responsible for 10 of these re-intubations. Patients with weight less than 5 kgs, age less than 1 year, CPB time more than 120 minutes, and presence of significant non-cardiac structural anomalies were found to be independently associated with the decision to defer immediate extubation. In a cohort of 613 children, including 97 neonates, decision to defer immediate extubation was associated with if a patient was on pre-op mechanical ventilation, similarly weight less than 5 kgs, longer procedure time, and the need for post-operative high inotropic support in these patients. In a cohort of 909 patients, immediate extubation was performed in 64.9% of patients, and a multivariable logistic regression model demonstrated that identity of anesthesiologist, year of surgery performed, CPB time of surgery was type of surgery was significantly associated with the decision to pursue immediate extubation. And immediate extubation has little or no effect on important outcome variables like ICU, length of stay in hospital after complex neonatal procedures like stage 1 palliation, arterial switch surgery. And early extubation is typically part of a fast tracking approach to patient care with defined goals. However, this does not imply compromise patient safety. Immediate extubation should be viewed as reducing unnecessary time on the mechanical ventilation rather than removing endotracheal tube regardless of the underlying patient's condition. Is immediate extubation a necessary component of ERAS? Although it is likely that ERAS protocols applied to pediatric cardiac surgery patients have potential to facilitate recovery, minimize cost, decrease both ICU and hospital length of stay, but it is far from clear that immediate extubation is a necessary or even a desirable component of successful ERAS protocols. ICU hospital length of stay can likely be shortened and patient and parental satisfaction achieved as a consequence of well-designed and executed ERAS protocol, and that does not require immediate extubation. 2 to 4 hour period of stabilization and observation in the cardiac ICU, it provides a margin of safety for us. And in the context of ERAS protocols, does immediate extubation offer any substantial advantage compared to early extubation, that is within 2 to 4 hours, after arrival in the ICU? The answer based on currently available information is no. So every patient is a possible candidate for early extubation. Individual approach is recommended considering all aspects like hemodynamic consequences of congenital heart diseases, extracardiac characteristics of each patient, and implementing a comprehensive early extubation strategy for all children with congenital heart disease is associated with low morbidity and shorter length of stay. Fast tracking in pediatric cardiac surgical patients is safe with probable clinical benefit and better use of resource. This model of management might be worthy of practice, keeping patient safety as top priority, with acceptance by all the team members to reap the clinical and the resource benefit. Thank you.
Thank you, Dr. Rohini, for wonderful presentation. She discussed
Thank you, sir.
all the merits and demerits of early and also the late extubation after cardiac surgeries. So the extubation, early extubation depends on starting from the patients, as he told clearly from the admission time. The patient should
Yes, sir.
know, yes. So starting from admission, whether the patient is on ventilator, mechanical ventilator support, or whether the patient is on renal failure, or whether the patient on refractory hypoxia, these are patients with the pulmonary hypertension. These are all some of the factors which restrict early extubations. As he told, as she told clearly, especially in Glenn surgeries and Fontan surgeries, it will benefited. But only thing is there should not be any complication of this. Example, this one obstructions, grading and all, it's all restrict the extubation process. In adult, we can safely extubate on table extubation, or that is immediate extubation can be performed with the single vessels disease patient coming for CABG correction, for CABGs, or ASD procedures, because the length of bypass period is very little. In pediatric surgery, we have noticed so many other institute they extubate complex congenital heart disease. Example, Norwood's or TGA surgeries, ASO surgery, ASO extubated on the table. But I feel little this one, because there's so many changes occurs after post-operatively. You have to see for each and every condition. You have to see the echo. Is there any residual? The patient temperature, bleeding, everything you have to look forward. Even during immediate, if you plan for immediate extubations.
Extubation.
Yes. So as you told clearly, the contraindications is bleeding, hernias, unstable hemodynamics with higher supports. Is it no?
Yes, sir.
Yes. Any Dr. Anup?
Yes, yes.
Yeah, yeah. You can
Yeah,
give
thank you.
your experienced this one.
Yeah. So I don't have much experience about pediatric cardiac surgery, but I'll invite my colleague, Dr. Ganesh, to share our experience from NH. Dr. Ganesh? So Ganesh is one of our senior intensivists who's managing our pediatric cardiac intensive care. So he will enlighten us about our practice in NH. Dr. Ganesh?
Till then, in
Yeah.
fact, they are. Yeah, continue. Dr. Ganesh, please.
Sir, Dr. Nagaraj here.
Oh,
Yes,
Nagraj.
yes.
Sir,
Tell me.
sir, Rohini, what was the pain management in most of these studies? What they've actually quoted?
Sir, for pain management in immediate extubation, sir, they have gone for regional anesthesia, sir. Caudal anesthesia in these patients, sir.
In all the patients, they have given caudal anesthesia.
Sir,
Most of them.
maximum, sir. Yes,
Most
sir.
of the patients, they have given
They have
caudal
given,
anesthesia.
yes, sir, caudal.
And what are they used for caudal?
Sir, they found excellent this post-op pain relief, sir, in these patients, post-caudal, sir. Requirement for opioids and all was reduced a lot. And they could early extubate, sir. Immediate extubation also was possible. There
And
was
how do
actually a good
you?
pain of relief. Yes, sir.
Okay, no, but how do you tell caudal anesthesia in cyanotic babies who are having coagulopathy? I mean, did they give caudal
Yeah.
anesthesia even in cyanotic babies who have this coagulation abnormality? Or which are the subset of these
Sir,
patients who are actually being caudal?
sir, that, sir, so sorry, sir, that I don't know, sir.
Okay. Okay. Because the most important part of early extubation or fast tracking in pediatric
Yes,
surgery
yes. Pain
usually
relief.
depends on pain management. Okay, if
Yes,
the
sir.
pain management is the pain management is good,
Yes,
and
sir.
even with the long pump run, also these patients can be
Yes, sir.
extubated,
Extubated early.
provided
Yes, sir.
provided these patients actually are on not any stiff inotropic supports.
Yes, sir.
So the stiff inotropic supports itself tells that the heart was pretty bad.
Pretty bad.
Even if it is a low pump run also, if the patient required a stiff inotropic support, then probably this patient cannot be extubated over a patient who
Oh,
has got a longest pump run but with a lesser
but
inotropic
lesser
support.
anatropic support. Yes, sir.
Okay. So what I feel is that if the inotropic supports actually play a major role in early extubation. Point number one. Point number two
Yes,
is
sir.
that if the pain management is pretty good in a pediatric babies, then
Yes,
usually they
sir.
can be extubated faster because, as you rightly told, the restlessness of the baby actually has caused most of the reintubation.
Yes, sir.
See, these babies cannot express pain, so probably the restlessness is because of
This is the
probable
pain.
pain. Yeah, so that is the main cause for probable reintubations in these babies. Okay, that is point number two. Point number three is, as rightly told, Prabhushankar sir rightly told, that these TGA babies who are actually acclimatized to a new physiology
Yes,
can
sir.
be extubated on table. But these babies, I mean, you should know what is the age of these babies also, because lesser age babies usually have a preserved ventricle. So probably
Yes,
these
sir.
are the
So
babies who
this.
actually have been
Yes,
ventilated,
yes.
who have been extubated earlier, because the physiology is now, when the ventricle is actually been preserved. So post correction, probably because
Yes,
of the
sir.
preserved ventricle
Preserved
or because
ventricle. They can be extubated early.
they can be extubated, but still, what is the point in actually, as you rightly told, so unnecessary ventilation is a very subjective matter. Okay, unnecessary
Yes.
ventilation, it can be unnecessary as an anesthesiologist for you, but it can be necessary for the surgeon. It can be necessary for the cardiologist. So it's
Yes, sir.
unnecessary ventilation is a term which is very subjective. So actually, the anesthetist should do the echo himself and should decide what is the ventricular function. If
Yes.
it is a left ventricular dysfunction, usually they do better with ventilating for 1 or 2 hours
Ventilation.
more. If it is a
Yes.
right ventricular, dysfunctional patients, usually they do better
They do
with
better with
faster
extubation, sir.
extubations. Yeah. So there are so many factors which are actually linked to extubation, or it can be fast tracking of the patient. It's not only the
Yes.
single factor, but
Yes,
most
sir.
importantly, it is the age of the patient or the pump run or the stiff
Pump run.
inotropic supports which actually dictate whether you want to extubate this patient. But off late, it is the serial echoes. When you do the serial echoes,
Yes.
how good actually the heart is
Good that.
actually responding post operatively, that actually makes more sense to decide on ventilation.
Sir, actually, in the study that where they have done immediate extubation, sir, they have actually, for all those patients, sir, they have done before extubations are TE. Like if there was no residual surgical defect and if ventricular function and all was good, only then they planned for extubation of these
Yes,
patients.
always
Otherwise, they were ventilated.
Yeah.
you have to rule out, is there any pathology, pulmonary hypertension, this one, afterload is more to the RV. Then, as we said, this one, no, early extubation is one of the skillful, it reflects the skillfulness of the surgeon. It is,
Yes.
one of the indicator in the this one. It reflects the skillfulness also.
Yeah. As rightly
Yes,
told,
sir.
see, sir is actually trying to tell early extubation is not actually how an anesthetist actually can
Yes,
extubate,
sir.
but actually it dictates the skill of the surgeon to handle the
Surgeon.
heart
Heart.
very delicately and do a proper job. So when he does a proper job, then extubation doesn't become difficult for an anesthesiologist. Because the heart is definitely
Yes, sir.
behaving good, and your job is just to maintain the physiological parameters.
Yes, sir.
Certain
Okay.
conditions where we cannot be though patient is fit, it cannot be extubated. Example, we associate it with valvular disease or myocardial, this one. Most of the time it involves the pulmonary as well as the pulmonary vasculatures. So this will restrict the early extubations,
Yes, sir.
especially VSDs, multiple VSDs, and all. It increases the more pressures for the vasculatures, and the lung changes will be there. So it takes time. So there are some of the conditions where cannot extubate immediately, or early
Yes,
extubation
sir.
cannot be performed.
Performed.
Ganesh, please.
Ganesh?
May I know? Dr. Ganesh, please. Anup,
Yes.
Yeah.
Can you
uh,
hear me?
can
Sir,
you?
can you
Yeah.
can somebody confirm you can hear me?
Yes, we can hear you. Yes, go ahead,
Okay,
Yes,
Ganesh.
sir.
thank
Yeah. Your
thank you.
experience.
Thank you for inviting me. And thank you for the presentation and by Dr. Rohini and Dr. Prabhu Shankar and Dr. Nagaraj view. So at NH, how we do is we actually have written a protocol, how and which surgeries we extubate early and what are all the criteria for extubation. We don't do standardized early extubations for all the patients. Each patient we individualize as the others gave their opinion. We go through all the data from the pre-op, intra-op, and post-op stage. And as the patient enters the ICU, we make that decision as a shared decision between anesthetist, surgeon, and ourselves, intensivist. And then we come to a conclusion, yes, we will go ahead with early extubation, or we also tell another term we use is called timely extubation. Timely extubation means we go through first 4 hours, no bleeding, hemodynamic stable, gas exchange stable, neurologic good, and we are confident that we have adequately covered the pain. We usually use dexam or dexmedetomidine quite frequently in our unit to control pain in little ones. And once all these criteria are fulfilled, then we will wean and extubate. It will be not 4 hours, it will be 8 hours. As you all may
Yes, sir.
feel, is another important criteria for as an intensivist is who is going to monitor the child after extubation is an important criteria for us, for me. I also look at the bedside nurse and what is the nursing strength in the later part of the shift. Also, the last criteria will be, is there a skilled person to re-intubate this patient safely? The next 12 hours will be an important criteria, because extubation is obviously easy, but we should not allow the child to struggle, and most of the critical events happen as we re-intubate the child. Either it is a delayed re-intubation or intubation was not done with a safety net of all the monitoring, and the intubation process as such happens smoothly. So we look at all these criteria, and then we decide on our extubation protocol. If I am allowed to share, I can show our extubation criteria. I'll see whether I can share.
Yes, sir.
Sure, go ahead, Ganesh. Yeah.
So I'll share my screen. So this is our, if everyone can see means or not tell us. Can you see the screen, please?
Yeah,
Yes,
we can
sir.
see the screen. Yeah.
So this is our extubation of children post cardiac surgery. So we first define the, as I said, as you can see on the top, the first line will be, we have to, the timing of extubation should be discussed between anesthetist, surgeon, and we group them into early, timely, or late as per the criteria. These are the list of surgeries where we go for early extubation. And then timely extubation are some surgeries where there may be some questions to be clarified to see how the child behaves. So these are some of the surgery. And then late extubation surgeries are obviously where we are very worried, really concerned things may go wrong as a team. Also, it's also based on our experience of dealing with these cases. We really know they will trouble us in the night. So we don't pull the tube early part of the evening. We'll just leave it for the night and keep the child safely muscle relaxed during that time. And if things are okay, morning we will extubate. So this is our physiological criteria to be met before extubation. So it's all the standard criteria about gas exchange, hemodynamics, systemic perfusion. And then some borderline cases also we give criteria that even though criteria may not be met, we will accept and extubate, where we will have a closer monitoring. And again, the more as criteria to hold extubation for 12 to 24 hours. As we discussed, there are physiological criteria not met, or echo shows residual lesions, or the bypass is prolonged. So then we go with how to optimize hemodynamics in these cases. And then another important criteria we tell our juniors on the floor is when we do borderline extubation, we always say we expect 2 to 5% of our patients likely to require reintubation. So we have a reintubation criteria also. Once we extubated, there are certain criteria our juniors will have to do. They will not like keep postponing reintubation, because we learned a lot. Like we push the child further and further, and then when we decide to reintubate, child is so sick, we reintubate, and then more and more iron probes are added. So some of these cases we do tell extubation is a trial. We may fail. We should be ready to reintubate. So these are all set criteria written based on discussion between our anesthetic team and maybe Dr. Keshamurthy, everyone know. So we speak among ourselves, and then we have made this criteria. And we also audit our performance and see any reintubation happened. Every monthly we do re-auditing also. Check any patients unnecessarily extubated and have to be reintubated. Mostly with this over the last, this was made actually during Corona time, we had some free time. We did successfully implement this criteria, and we also use quite a lot of non-invasive ventilation, which we started to use in babies less than 1 year in the last 1 year also actually in infants. And that has fast-tracked many of our extubation, and our average ventilation duration varies between 12 to 18 or 18 if we combine all the surgeries together. So that's how we do in our unit.
Thank you, sir, for your sharing your experience. It's a good on-table extubation you do. This one only
No, sir.
ABC. Only you see the criteria of arterial blood gases, or train of 4 and all you assess.
On-table extubation is very rare.
What are the surgeries on table?
Our team,
What are the surgeries they are?
On-table extubation is not done in our institute that frequently, sir. Maybe less than 1% of cases.
On-table are early, less than 2 hours or 3 hours.
That cases, as I showed you here, sir. These are the cases. I'm just
no, because TAPVC was there. TAPVC. So TAPVC, is it possible to extubate early, because we have to see the LA conditions, the pressures, everything?
There are 3 different TAPVCs. This is who is older children who are very
compliances.
They are not. Some of the other TAPVCs will be timely extubation, like cardiac TAPVCs.
Okay.
If you see intracardiac TAPVC, we will not extubate for 48 hours.
Yes.
So not all TAPVC come under same groups. If the TAPVC is very which behaved like a ASD pre-op without much hemodynamic concerns for the patient, and the surgeon and anesthetist feel it is safe to extubate, we extubate. So most TAPVCs comes under the group of late extubation, sir, because our TAPVCs have a complex background, and many had multiple infections, failure to thrive. They are very sick when they come to us. So they will come under late extubation.
Because I've seen in the early extubation TAPVC, only
Yes,
supracardiac.
Very stable supracardiac TAPVC, sir. That's here mostly straightforward single ventricles like Glenn Fontaines we do. That is straightforward to be extubated within 4 hours. And then ASD, small VSDs, partial anomalous pulmonary venous connections, and coactation, PDA, AVCD, LVOT, RVOT relief, RV2PA conduit, double aortic arch repair, and transatrial ICR, and Wazaki procedure where no concerns post-op, we extubate early. The other surgeries we extubate timely is we look a little bit longer is infantile TAPVC, it's cardiac and supracardiac without any pre-op concerns. And again, some VSDs with a moderate pH, VSD with RVOT relief, VSDs with valve repair, but no other concerns. Rupture of sinus of Valsalva, PA band, and older BT shunt, Ross surgery, classical CCTGA repair, Sennings, aortic valve repair, cortriatrium, and atrial myxoma. All these things, only if all the criteria are met. All the remaining complex surgeries comes under late extubations. Okay. So the most, more than surgery, our physiological criteria, we make sure it is fulfilled.
Yes.
Gas is fine, hemodynamics okay. As you both explained before, all the criteria of systemic perfusions is good. Like venous blood gas saturation should be 65 to 80. There should be no acidosis, and reasonable urine output should be there, and lactate should be less than 2. If all these criteria are met, then then only we consider the child is fit for extubation, and then we pull the tube out.
Okay.
We do borderline extubations even if not, but we prefer to, depends on the team, and as I said, how the nursing monitoring will be, how the person is the team will be able to re-intubate if the child becomes sick in the night. Those criteria we take, and then we push little bit further, like little bit earlier extubations in some of the scenarios. So this is how we follow the process in our units.
Thank you, sir, for your timely sharing your experience.
Welcome, sir. Thank you.
Yeah.
And
any.
Thank you, Ganesh, for that for sharing our experience here. So I believe it will be quite beneficial for all the attendees over here, just to get a glimpse of what we do at our institution. And I see that there are no more questions in the chat box. Is there anybody else who would like to make a comment or share with us the experiences that they do at their institution?
Sir, can I add one point?
Sure,
Yes.
Ganesh. Yes.
Regarding whatever we read in the literature, I just want to share my opinion. Some of, I think Anup may know, I have worked overseas as well. So what we see in literature is extremely individual center specific.
Yes.
Skill set, nursing skill, and resource skill, there are beyond the limit, which we can't even assume what support they have if a child deteriorate. And it may not be easy to just extrapolate that data into our practice. I think, for example, if I come and work in other institute, I can't just come and say, this is my protocol, you have to follow. So obviously, as we all know, every institute, particularly when it comes to cardiac surgery, it's very, very specific to the institute how the practice is. It's good to see how others do and what they do, definitely. I just thought I will let you know, because we were learned ourselves when we push for early extubation, and then we sit next to the patient all night, what to do, and then somehow we push them out. So it's not standard all the time. It's not easy to follow international practice in our setting at all times.
Yes, that's true.
Yeah.
Ganesh. So shall we just summarize since there are no more questions in the chat box, and anybody else would like to make a comment here?
If there is no
yeah, in that case, we'll
yeah.
just wind up the meeting. So I at the outset, I'd like to thank Dr. Rohini for that wonderful presentation. So she has taken the effort to present to us both the pros as well as the cons of early extubation. So summarizing from the talk, it would seem like early extubation is obviously a benchmark that we should all aim for, but it is not applicable for all patients. As Dr. Ganesh has rightly pointed out, we have to streamline depending on local resources as well as the surgery that has been done, and some multiple factors have to be taken into consideration before we can take a decision on early extubation. And obviously, it has to be a team effort where a detailed discussion between the anesthetist, the surgeon, as well as the intensive care team, and together a team decision is taken so that an optimal outcome is obtained. So then there are several factors, as Dr. Nagaraj has also said. Pain management or pain relief is a very critical aspect about that will determine successful early extubation. And also Dr. Prabhu Shankar has also highlighted several other points as well, hemodynamic parameters, metabolic parameters, and temperature management. All those factors should be satisfied before we can consider early extubation. And also the article says that immediate extubation can be done, safely done, and there is evidence base to prove that immediate extubation or extubation within the OR is a very feasible approach. But we also have to look into the local conditions also, where support staff, the institutional, the volume of cases, and all those parameters, as Dr. Ganesh had highlighted. We have to take those factors also into consideration before we look into immediate extubation. But overall, early extubation is a very good option, and I thank all the attendees as well for joining in, and also for the lively discussion that has been happening here in this forum. So with that, on behalf of Forum of Cardiac Anesthesia, I thank everybody and wish you all a good evening and a good night.
Thank you, sir. I thanks Dr. Rohini especially. She presented wonderfully in a simple way. She included all the factors, both for the early and late, and also thanks for everybody. Thank you, sir.
Yes, thank you, everybody. Thank you. Yes.
Thank you, sir.
Yeah.
Thank you, Anup sir. Thank you, Ganesh sir. Thank you, Prabhu Shankar sir, and thank you to Dr. Rohini. And thank you all the attendees to attend the session. I just wanted to inform everybody, as everybody knows that we will be doing session on Sundays, breakfast session. For a couple of weeks, it's not been happening. So these classes will be starting from 12th of September, and it would be a continuous classes for the TE sessions. Requesting all to please join this session, breakfast session of TE. Thank you all. Good night. Thank you.
Thank you, Rajiv. Thank you.
Thank you, sir.